Okay, very good evening to all the participants in this webinar. I welcome you all on behalf of Infant and Young Child Feeding Chapter of Indian Academy of Pediatrics and Human Milk Banking Association of India and PATH together. We are very thankful to PATH for coordinating all the meeting today, and we are hopeful that everybody will have some good message at the end of the webinar today. Friends, COVID situation is there as pandemic, and we all are affected by it. And added to that, the lockdown situation has created more and more complications. From our last experiences with SARS and MERS infections epidemics, we are all scared because of the coronavirus fatality rates and the morbidity rates. And from past experiences of MERS and SARS with high fatality and presence of MERS seen in camel milk had always raised issues and doubts in our minds regarding whether breast milk is safe for our newborn babies or not. We have examples of HIV being transmitted by breast milk, cytomegaloviruses being transmitted by breast milk, presence of hepatitis B virus in the breast milk. All these have raised many questions in our minds. Above that, there are other modes of transmission possible from mother to the child, as vertical transmission in utero, horizontal when the mother is with the baby, and even now people are thinking of reverse transmission from baby to the mother. So, and there are no authentic data or structured studies available, and there are only scattered observational reports are there that this COVID virus is not present in breast milk, and most of the newborns of the COVID positive mothers and the COVID positive newborns are also otherwise safe. These are heartening things which we are having at present. But then, still we need to have a lot of discussion and scientific data on it. And for this, we have organized this webinar. And we have got an expert panel, and we have got a senior from Ministry of Health, Dr. Ajay Khera, leading us. And we have got faculties from UK, Gillian, I welcome you, Daniele from Brazil, Dr. Jaoy, and our own members, they are there, Dr. Sitaraman, Dr. Swati Manekar, Dr. Sushma Nangia, and others who will contribute to this webinar today. Friends, they will talk about everything, but then let me give you the focus of the discussion, that we will be discussing much on whether to keep the baby with the mother, that is, whether we should advise separation or not, whether the breast milk is safe if it is given directly from mother, whether mother can remain bedded in with the child, whether donor milk is safe. There will be many questions on donor milk also, and of course the logistic issues in implementing the current guidelines which are given by the government. Let me set the ground rules first, that all the delegates in this webinar will be muted. Please post your introductions in the chat box and raise your hand, or rather put your question in the chat box to the panelists, and we will answer you. And so far as this whole webinar is concerned, recording is being done, and you will be shared with the recording and the presentation both. So don't worry about it. You can review it later on. connection, yeah. So, for knowing the current status of how people are working, we have planned a small poll. Apurva will post the poll over here, and everybody will answer those questions. All the delegates will be able to answer those options over there. At the end of the 10 questions, there will be an option for submission of the poll. And after about 1.5 minutes, we'll have the result of the poll from the host end. So let us have the poll. Apurva?
Okay.
Will you go for the next?
So should we end the poll? It's already 2 minutes.
Just take half a minute.
Okay. Okay.
So we'll be ending the poll after 10 seconds. Yes, Apurva. Now we can end the poll and you can display the results.
We have ended the poll. Should I share results now?
Yes, yes. So we have got the results. Are you facing unique challenges in newborn feeding and maternal support in current situation? 62.8% participants are facing it. Number two, are you practicing early skin-to-skin contact and breastfeeding or separation of newborn delivered by COVID positive or suspected mothers? Yes, majority are practicing skin-to-skin contact and breastfeeding. What is the routine practice for newborn of COVID positive mothers and suspected mothers? Majority, the house is divided 50-50, almost 50-50 between rooming in and separation. Number four, if the room is then, if there is rooming in, then is the baby bedded or kept at 6 feet distance when not feeding? Again, majority are keeping a good distance when the baby is not feeding. Number five, are you practicing KMC in COVID times for overweight babies? Again, the house is divided almost equally in yes and no. Does your facility have any milk bank? Majority don't have it. If separated, what is fed to the newborn? Again, a majority of them are feeding mother's own express breast milk. Though majority don't have donor human milk, then still 18.6% are able to get it. Otherwise, they are giving formula milk or animal milk. Mothers are being supported for lactation after discharge. This is a very heartening observation among majority. How are the mothers supported after discharge? Majority, they are doing with telephonic consultation, and even now Government of India has also given the guidance that you have to give more and more telephonic consultations. Are you able to support the mothers as efficiently as previously? And again, the house is divided almost in 42% and about 57.9% are able to do it. This is again a good sign. Now we proceed over to next part of our discussion, and it will be the deliberations by various speakers. And for that, I would like to invite Dr. Sitaraman, a very senior pediatrician from Jaipur, and he is also the center is also approved as a regional excellence center for comprehensive lactation management centers. I welcome Dr. Sitaraman here. Please take the charge, and we too will moderate the session as the session progresses. Welcome, Dr. Sitaraman.
Good afternoon, all of you. I must welcome all my national and international faculty and panelists here. Especially, I am quite thrilled to see Gillian and Daniel and Joe and even Dr. Kera taking out from the busy schedule. And I must really appreciate and thank you all for giving us time, because the very fact that you are here tells us that the importance of the issues currently under consideration. And PATH has actually really taken up the initiative, and it is extremely important for us to understand that the issues which have cropped up, and including the polling which you just saw, let's not take the 52 or 54% of the positivity. Let's take the negative aspect of it, that people still have, nearly half of them have doubts on practically every aspect of this problem. And these things have to be cleared up by the panel. We have such a distinguished panel with us who can share their experiences. Meanwhile, I'll be commenting in between. And we have a range of people, right from explaining the policies of various associations to the what we call the COVID warriors who are working with them closely. And of course, we have the institutional heads who can make a clear policy decision on how to take us forward, or what do they expect from all of us. And in turn, what do we expect from all of them, especially the government. And we do have an international experience from our friends from UK and Brazil who have had their own set of logistic problems. And I'm quite sure they will be able to tell us how they have been going around solving that. To cut it short, I'll invite Dr. Ruchika Sachdev, now who is the, who was actually the key person to start all these proceedings. Uh, she's a member from the PATH who has been representing for every aspect of human milk banking in our country, helping all of us practically. She will be deliberating on the basic guidances issued by various bodies throughout the country and the international faculties. These are the guidelines which have been issued, which will be put it up for you for consideration. But then we'll have practical aspects, and of course how it goes down to the ground reality, whether guidelines do need some changes over in our country or outside. I'll hand over to Dr. Ruchika for continuing the same.
Yeah.
Yes, Dr.
Thank you so much. Can you hear me well? Yeah. Thank you so much, Dr. Sitharaman and Dr. Ketan. We all acknowledge that these extraordinary times we are having a devastating impact on our essential healthcare services. And this has also been recently shared in Lancet article, the work which has been done by Tim Robertson, using the list modeling tool. He has also looked at how the disruption in healthcare services and also decreased access to food is impacting our maternal health and also newborn and child health. And the data has seen that with reduced coverage over the next 6 months, we can have a devastating impact in terms of our maternal and both neonatal and child health mortality. So this basically underlines, as Dr. Ketan was also saying, there is a need to ensure quality of care for our moms and babies. So what we know about COVID-19 and breastfeeding, I think all of us are aware that breastfeeding and use of human milk is important at all times and is of particular importance during emergencies and natural calamities. For babies born preterm and for infants born in resource-limited settings, a non-breastfed child's risk of death is 6 times that of a breastfed child. And also, if you look at the recent evidence which we have on COVID-19 and breastfeeding, as far as now, there is no vertical transmission which has been documented. Antibodies and bioactive factors in breast milk may fight against COVID-19 infection if baby is exposed. And also the children who have got, the neonates who have got infected by their COVID positive moms typically have shown mild symptoms as per the experience suggests, and Dr. Sushma and Dr. Swati are going to talk more about it. So it's really important, while these guidelines have been formulated by the national and international bodies, proven benefits of breastfeeding must be weighed against potential risk from COVID-19. So they have looked into it. So we have global and local guidance from professional bodies, WHO, CDC, ICMR, then Global Milk Bank Association, be it HMBAI, EMBA, and our Human Milk Bank Association of India. And with evolving evidence, recommendations are also undergoing periodic modification. So I'll start with the WHO guidance, which says for a COVID positive suspect or a positive mother, one needs to follow a standard infant guidelines, initiate breastfeeding within the first hour, exclusive breastfeeding for the first 6 months, and continued breastfeeding. There is no change in the guidelines. The guidelines needs to be continued as they are. All the guidelines, be it WHO, CDC, ICMR, and our professional body guidelines, talks about infection prevention, both hand hygiene and respiratory hygiene. And if mother is unable to directly breastfeed, they focus on expression of milk, followed by, if the mother is unable to breastfeed or express milk, a pasteurized donor human milk can be given from a milk bank. And the sick mothers who are unable to breastfeed while they were sick, they need to be supported for relactation. So there's a lot of emphasis on that. WHO also emphasized do not separate mother and baby, practice skin-to-skin contact, or kangaroo mother care, taking due precautions. Kangaroo mother care is one area where we need to really look at evidence, and a lot of at the practical level, I think again the challenges would be shared. in terms of how various facilities are ensuring kangaroo mother care and skin to skin contact. And then all the guidelines are focusing, since we are in the trying times, are focusing on the psychological support to be provided both to the moms and their family members as well. WHO recently came up with the decision tree and an FOQ, which help guide the healthcare providers and the people working in this area in terms of taking a decision regarding to newborn nutrition and care, which is a very good resource. Coming to CDC, they've come out with the interim guidance and they've revised it pretty frequently. They say whether or how to breastfeed should be determined by the mother in coordination with the healthcare provider. A mother, if it's suspected, probable, should be counseled and precautions should be taken for infection. CDC is focusing more on express breast milk rather than direct breastfeeding. And they say that the express breast milk should be given by the healthy caregiver. And the infant who's breastfed by the confirmed COVID-19 positive mother should be considered as a suspect while taking all the infection prevention processes. CDC recommends telemedicine in terms of providing lactation support, which is also recommended by the ICMR and also our professional bodies guidelines. Again, ensuring that the quality of care is followed, it recommends and encourages to prioritize newborn care and vaccination, which is really important. And also, it is also laying a lot of emphasis on weight checks, on assessment of jaundice, and every effort should be made to conduct newborn follow-up visits in person. And we know we are seeing a lot of lockdown, so this is another challenge which is being practically faced, which I think our co-panelists will talk about. Coming to the donor human milk bank guidelines, which have been issued by the Human Milk Bank Association of North America and also by EMBA, which is pretty similar. First, I'll talk about the evidence which is available so far. So the data says that there's complete heat inactivation of the genetically similar virus SARS and MERS has been reported at 60 degrees for 30 minutes. And also the SARS coronavirus significantly reduced when heated to 56 degrees for 10 minutes, and it was completely inactivated within 30 minutes. Now there are two studies which are underway in breast milk as well. So they will be of, for good significance for us in terms of determining what process should be followed for the donor human milk collection processing. Also, the donor milk dispensed by Hambana uses the holder pasteurization method, which is also universally used by most of the milk banks, around the world. It talks about strict donor screening, validated pasteurization, and third-party microbiological testing, which is again being talked by EMBA and also our Indian guidelines. Donor screening includes detail of international travel, recent illness history, including family travel, and also if the person is coming from the containment zone. So they are all similar and based on the WHO guidance. Mothers are deferred based on the responses. Coming to the EMBA guidance, they are very much similar to the Hambana guidance. Since in Europe and many Western countries, they have longitudinal donors wherein a mother continues to donate milk for a longer period of time. These guidelines are really laying emphasis in terms of ensuring if the mother is suspect or if she is COVID positive, then the collection would be temporarily suspended. And once she recovers, she's tested negative, then only the collection should be resumed. Again, as I mentioned, EMBA guidelines are similar in terms of following strict hygiene rules regarding collection, storage, and handling of donated milk. Coming to India, the Indian government is laying due emphasis, and Dr. Khera will talk about is continuation of essential health services, right from the antenatal care, breastfeeding, kangaroo mother care, early initiation. So there's a lot of emphasis. There is guidance from the ministry, which is there. The ICMR guidance, the Indian Council of Medical Research, which is a premium institute in India, has given guidance for the management of pregnant women, wherein they are talking about that the woman to be asked about mental health at every contact. So it's really important. We are in trying times, as we mentioned. So a lot of emphasis is on mental health and also on teleconsultation, and antenatal care should be taken through teleconsultation and routine home visits with PPE to be followed by the healthcare provider. The ICMR guidance talks about temporary separation of confirmed COVID-19 mothers or suspect as a first option. until the mother's transmission based precautions are discontinued. During separation, express breast milk needs to be given, and a lot of hygiene practices needs to be followed for using the breast pump, which needs to be dedicated. If the mother is roomed in with the baby, given there are facility limitations, then she needs to breastfeed taking all precautions and maintain physical barriers when not breastfeeding. So these are the guidance from ICMR. On the other hand, if you look at the guidance from the FOXI, which is our gynecology, professional
Ruchika,
body.
we got 1 minute.
Yeah, National Neonatology Forum and the Indian Academy of Pediatrics, they lay more emphasis of rooming in and breastfeeding as a first option for the stable neonates, and they're also laying emphasis on the family member or the nurse providing support to mother and baby using a PPE, because for ensuring newborn nutrition and care, it's really important that the mother is supported well. If rooming is not possible, they talk about express breast milk. They don't talk about the donor human milk use. And the FOXI and NFIP guidance, which was revised very recently, also talks about the suspected and confirmed COVID-19 cases, how they need to be isolated, and also how sick neonates need to be isolated if their mother is COVID positive. In the recent guidelines which have been revised, they also mention about, given the cases in India are really increasing, they are talking about if the baby is stable, the mother is stable, and if they've been roomed in, they can be discharged early. And also, if the baby is not roomed in and the mother is in the hospital, they can be discharged with the family member within 24 to 48 hours. The question, I think, which the panelists will raise is in terms of also ensuring that the family members are not suspect, given the mother is a suspect. So yeah. The National Neonatology Forum has also come out with this COVID-19 registry form for neonates, which they are encouraging health facilities to use for tracking the feeding and the treatment protocol. So this will be very useful as we move along and we get more information how the treatment is being managed. So so all the healthcare providers are encouraged to use this platform in terms of recording the data for the neonates. The HMBAI, IAP and IYCF chapter guidelines are again very similar to the NNP and the IAP guidelines in terms of breastfeeding and also in terms of expression. They have given additional guidance in terms of the use of donor human milk, and also they talk about providing additional counselor support with PPE for mothers, given there's a lot of education needs to be required regarding the COVID-19 behaviors. It talks about giving pasteurized donor human milk in line with the national guidelines of lactation management. Again, the donor screening criteria to include additional contact, travel risk, and exposure history details. Strict hygiene procedures during the milk collection pasteurization to be followed. And if there is shortage of pasteurized donor milk, which the facilities will talk about they are facing, then the donor human milk dispensation criteria can be reserved and can be given to more vulnerable babies. The formula needs to be used only as a last resort. So here I will be ending my presentation. As we'll get more evidence, the guidance will be would be evolving, and it's really important for us to work together to ensure how we can ensure the quality of care as we move along. And I think now our co-panelists will talk about the ground level challenges, given we have guidance from various bodies. Thank you.
Thank you, Dr. Ruchika. I'll now invite Dr. Swati, who's an additional professor of neonatology, Lokmanya Tilak Hospital, Zion, and also in charge of the Zonal Reference Center, to give us the ground realities in this particular situation. I'll definitely insist upon that we maintain the time of 8 minutes, because we are getting some questions which are coming in rapidly, and we do have to answer some of those queries. Meanwhile, when I would also like to comment upon the varieties of the rulings which have been come out with so many recommendations from various concerns from the bodies, how it has been, could it be applied in totality to their situation or not? That should be a final take, and what they have modified I expect Dr. Sushma and Dr. Swati to answer that in our local context. Dr. Swati? Dr. Swati online? Can't see her.
Yeah. Can we ask Dr. Sushma to present while Dr. Swati is connecting?
Yeah. Professor Sushma is a director professor in Kalachcharan Hospital, and she is one of the leading member who is so passionate about Human Milk Bank. She is the national coordinator, and of course, she is going to tell us something more about how she has been handling her COVID mothers there. Dr. Sushma, please. You have to unmute yourself. Yeah. Still muted. No, Dr. Sushma, you have to unmute.
I'm unmuting.
Yeah.
Done? Okay.
Yeah, done.
Yeah. So good evening, everyone. And good evening to all the esteemed panelists, as well as to all the viewers. Is the slide visible?
Yes.
Okay. So I'll be talking about the maternal support and newborn nutrition and care during this pandemic as to how it has got affected and experienced really from Lady Harding Medical College. So what you see here is a team, and this picture was clicked day before yesterday on the occasion of International Human Milk Donation Day, and we have the support staff, the residents, the nurses, counselors, and the milk bank manager here. And this is just in front of our milk bank that the whole team is functioning, and the milk bank has been functioning during this pandemic. Okay, I've been asked to kind of focus on certain aspects of mother and the baby. So I would start from the antenatal care. So far as the antenatal care goes, our obstetricians are insisting on minimum of 4 antenatal visits, and which haven't changed in terms of the timings, which is 12, 20, 28, and 36 weeks. And if there is an issue, then the rest are tailored as per the doctor's discretion. But in case at the time of the antenatal visit, the lady has some symptoms, then she has to defer her appointment till about a week. Or if the symptoms are severe, then of course she has to report right away. And if she has to come for antenatal ultrasound just for fetal growth surveillance or something not very important, then she has to wait till about 2 weeks till the resolution of her acute illness. So if she's symptomatic, this is what they are following. However, if the woman is in self-quarantine, that means she's had a household contact, then of course she has to defer her appointment by 14 days. Now, in this case, or in any such case, if the appointment that has been scheduled and the woman does not report by more than 3 weeks, then the facility needs to get in touch. And I must confess that this is not happening absolutely on dot, but this is being tried. Excuse me. And testing for COVID-19 should be as per the national guidelines given out by the Indian Council of Medical Research. And during the COVID-related counseling to the mother during the antenatal, we are ensuring that social distancing being referred to, hand hygiene is being referred to, symptoms as to what symptoms they can expect and what are the danger signs when they should report right away. So national testing guidelines, of course, we are all aware. And if there is anybody who is symptomatic with influenza-like illness with a history of travel or history of contact, or a healthcare worker who is involved in the containment or mitigation, or if it's a SARI-like illness, or if these are returnees from migrants within 7 days of the illness, or they are hospitalized patients, like you have somebody who's hospitalized for, let's say, GDM management. And during her hospitalization, or for that matter, if she has been hospitalized because of preeclampsia and she develops influenza-like illness, she needs to be tested. Asymptomatic direct contacts, which is mostly the healthcare workers, and we could have some nurses and people who are pregnant and they are working, so they need to be tested if they have been a high-risk contact within 5 or 10 days of the contact. What I need to emphasize here is that if there is a lady who's coming from the containment area, then even if she is asymptomatic, she needs to be tested if she is likely to deliver in the next 5 days. At the same time, this also needs to be emphasized that no emergency procedure should be delayed for lack of testing. This needs to be taken as it could be suspect COVID, go ahead and deliver her, or go ahead and do a section and follow all the precautions. The test can be done and the reports can be looked at later. So as soon as this thing came up, we had to create certain areas within the confines of our physical space and the manpower. And these actually included COVID suspect mother, COVID positive mother, pre-delivery, where should she be admitted, post-delivery, which is the area where we need to put her, separate birthing areas for non-COVID and for those who are COVID suspect or positive. So if she needed a LSCS, separate OP, or a separate vaginal, for separate vaginal birth, separate labor room. So these had to be created from within the places that we had. And baby born to COVID suspect or positive mother, if the baby was healthy, not requiring NICU admission, the baby was going to a COVID postnatal ward. And if it was sick, of course, we have created a neonatal COVID facility, the NICU, where they are going. So ideal situation will be that you have 4 different areas where you have baby. If the baby is fine, where do they go? They remain with the mother. They are roomed in. If the mother is unwell, the baby is in a separate place receiving EBM. If the baby is sick and born to a COVID suspect, one NICU or SNCU, and if the baby is born to a positive mother, another one. But in practical situation, this was really not possible to do it in as many places. So what we had done at our hospital level was that the baby could be stable, A and B, and the baby could be a baby who is requiring hospitalization or admission into the NICU, C and D. So A and B could be COVID suspect mother's baby or COVID positive mother's baby. They were going to a COVID postnatal ward with a healthy attendant, and they were being provided express breast milk. Whereas if they were requiring hospitalization, as I said earlier, they were going to a neonatal COVID facility, which we had created separately from our usual NICU. And of course, the babies were being only tested if the mother tested positive. If there was a suspect mother who tested positive, only then we were testing the baby. Or if the baby right away required admission into the neonatal COVID facility, he was being tested. Our policies regarding immediate newborn care, so I am not going to the resuscitation aspect, but yes, delayed cord clamping was being followed right from the beginning. As we all know that vertical transmission is really not proven, and the baby gets a lot of benefit because of delayed cord clamping up to 60 seconds. Skin to skin contact can be practiced. Again, I must confess that this is not being done universally in our birthing area. We are working towards it, and we hope to be better at it as time goes by. Bathing is not recommended, and these are all recommendations from FOXI and NFIAP. And of course, we are also not bathing our babies because of the risk of hypothermia. Breastfeeding, yes, that's the big forte that we have been able to try and achieve. So these babies need to be exclusively breastfed because we know that the breast milk is not infected. It does not contain the virus. In fact, the breast milk contains protective antibodies. So if the mother is really a positive case, her breast milk is likely to contain antibodies against this virus, so which should be fed to the baby. And that's a good chance for the baby to be protected. Feeding options were really roomed in, so babies could be directly breastfed. If not roomed in, if it is not possible, you don't have that much space, as is the case with us, where we cannot keep the baby and mother separate by 6 feet. So then you give them express breast milk. So this was our way of doing it, that mothers own milk in COVID suspect or confirmed mothers. So lactation counselors were going to these areas, manual expression was being taught. They were also being given lacta sets, and of course, hand hygiene and droplet precautions were shown. And you can see some of the containers, which are sterile disposable containers, coming to the hospital for various samples that we sent for testing. So these are sterile containers in which the milk is being collected and it's being dispensed. And you can see our lactation counselor, who was in a PPE suit, complete hazmat suit. She enters the area which has COVID positive and suspect mothers. And here she is counseling, checking some of the details of the mother, counseling the mother, and then she is helping the mother express the breast milk as to how she should be expressing the breast milk. And that's what is collected in the container that I just showed, and that's being fed to the baby. For the babies who are admitted in our NICU, we have no change in the enteral feeding practices. They remain unchanged. And the baby, if there's no contraindication to feeding, the baby receives exclusive breast milk. Or if mom is not available, which means mother's milk is not available, then babies larger than 34 weeks get formula feed, but smaller ones are getting donor milk. And as and when the mom becomes available, the baby is on exclusive mother's own milk. And wherever I've shown a red dot, that's the area where our lactation counselors are helping the mothers wherever the mother is admitted. Counseling session by our lactation counselors and by the NICU staff in the KMC area and in the milk bank at the pumping station. People are very concerned, and this was one of our largest concerns, was kangaroo mother care. So some of our own team members said that these mothers are in the postnatal wards, they're going to the canteen, they are roaming around, their husband is coming to meet them, and so on and so forth. So they could be asymptomatic carriers, and we should not allow them into our usual NICU. I'm not talking about the COVID NICU right now, the usual NICU. So that was the concern. And we had to really brainstorm and bust the myths of all our nursing colleagues and of course our own faculty and residents. And now you can see this picture clicked on the 15th of May, which was the International KMC Awareness Day. You can see a baby on respiratory support, mother providing KMC, of course, with all the hygiene, hand hygiene, and they are wearing their masks, they are using our hospital gowns, and these are our counselors and nurses who are there with them. So we are flawlessly providing kangaroo mother care to all our babies in the NICU who require to be given kangaroo mother care. In the kangaroo mother care ward, mother is also feeding her baby while she is giving KMC to a extremely small baby. Donor milk and our CLMC, our mothers are not getting tested, not all of them. So asymptomatic mothers, not everyone is getting tested. So we formulated our own guidelines right in the beginning of this pandemic. And we said if the mother is symptomatic herself, she complains of any fever and we check the fever. If she has fever or cough, she is not. If she has contact with a confirmed case or she's from a hotspot or containment zone, then this is the woman we are not letting her enter into the milk bank, in the sense that she is being counseled regarding breastfeeding and manual expression. Milk expression using electric breast pump and donation is performed only if above things are not there, the above three things that I said. Process of collection, processing and supply of PDHM remains unchanged. Our NICUs are getting PDHM from the milk bank, and this is being used for babies who are less than 34 weeks. What I must confess here is that the volume of donation has been impacted. One, because the number of mothers that are there is less than before. And second, because of this issue of mother may be positive, and if she has any of these things, she's from a containment zone, and so on and so forth. So the volume really has come down, and it's dwindling to an extent that we may run out of PDHM very fast if we don't have donations being done. We are counseling, our counselors are going and talking to the mothers and counseling them. So this is the social distancing, where with social distancing, manual expression is going on.
Sushma, we are hearing
1 minute?
1 minute, yeah.
Okay, I'm almost at the end. So then the discharge and follow-up, we have such a lot of circulation of the mothers, although in COVID times it's come down. So actually stable babies are being discharged by 24 to 48 hours, and mothers are being discharged even earlier after their test has been taken and the result may or may not have come, because of the volume that is increasing. And now with the lockdown going away, in the last 3-4 days of this week, from Monday onwards, the numbers have started increasing as to how many mothers are getting delivered. Sick babies, of course, they are in the neonatal COVID facility and discharged as per the unit policy. So the last thing about our story, 30th January, all of us know that first case in India, 2nd March, first case in Delhi, 24th March, lockdown was clamped. In Lady Harding, we had the first case in the first week of April, and a first COVID suspect mother delivered in the 2nd week of April. In the last 1 month, we've had 155 mothers, of which 56 have been symptomatic with fever, cough and stuff. Others are all asymptomatic from containment zone. So they are the only ones who are being tested. Mode of delivery, it isn't as high as I have read some of the reports, 31% by cesarean section, the rest by vaginal birth. All of them have been tested, and about 20% positivity. 30 mothers out of 155 have tested positive. These all mothers have been discharged home for home isolation, which means they were not greatly symptomatic, they were mildly symptomatic or asymptomatic, and no reported maternal mortality or maternal serious morbidity. Babies, all 30 that we tested are negative. We have had 2 babies who were delivered outside, and the mother and baby were together, and those 2 babies were tested positive around the 4th, 5th day. But when we did their test around the 14th day, both have turned negative. So I think I have all this to present, and I'll be happy to take questions at the end. So my sum up is that together we can achieve things, although in the beginning they appear really difficult and you are like bogged down as to how this will be done. But with your team, I think it's possible. Thank you so much.
Thank you, Dr. Sushma, for such a comprehensive overview of the situation. And I must compliment you on your presentation. And here I'll definitely like to share our experience where we we are fortunate to have one of our whole women's hospitals separately designated as a COVID hospital, where we had nearly around 500 babies, 500 suspect mothers, of whom 62 turned positive COVID mothers, and 3 of the babies turned positive. But fortunately, none of the mothers and babies had any morbidity or mortality. And I think that's good news from the mother and baby point of view. Now I'll like Dr. Saraswati to join in, who is an additional professor of radiology in Sion Hospital, Lokmanya Tilak Hospital, and also the in charge of the Zonal Reference Center. Very crisp and short presentation on 8 minutes would be welcome.
Good evening, everyone. Am I audible?
Yeah.
Okay. So thank you so much for having me here. And the story from Mumbai is probably worse than what it is in the remaining part of the country. Lokmanya Tilak Municipal Medical College, it's one of the busiest public hospitals in Mumbai. We have around 10 to 12,000 deliveries per year, 40 bedded neonatal unit, but very, very crowded, 3,000 admissions per year. And we also have the Human Milk Bank, now the Comprehensive Lactation Management Center and Zonal Reference Center. And we bank about 1,000 liters of human milk per year. Sounds like a real wow story till the COVID started. We've focused on family-centered care always. We've always allowed mothers into the unit. They would come in, interact with their babies, help in baby care practices, express their milk, give kangaroo mother care, feed their babies. And if the mom wasn't available, we would allow some other lady relative, so a grandmother who could come in and work with the baby. Till about mid-April, no asymptomatic COVID mothers delivered, and we weren't really sure about what is the COVID status of asymptomatic mothers who were coming into the hospital. This is just to give you a brief overview about the hotspots in Mumbai. Maharashtra is one of the most affected states, and Mumbai is the most affected city. And as you can see, there are red spots all over. And we are somewhere here, close to Dharavi, right in the middle of the epicenter of the epidemic. And we drain patients not only from Dharavi, but from all these areas around. And we weren't really aware of what was the status of pregnant women and mothers who were delivering till the new strategy for testing asymptomatic mothers from hotspots and containment areas came in late April. So mothers would get referred. These are all high-risk mothers, and if this mother happened to be symptomatic and happened to have a test done with a positive report, she would directly get referred to the dedicated COVID hospital in the Mumbai area, which is the Nair Hospital. If she came in advanced labor, she would be delivered in the emergency COVID OT with all universal precautions. But delivery of asymptomatic women with unknown status already in labor was something which really came as a shocker, and it created chaos for a while till we figured out how we had to manage all these things, because it would involve segregating the suspects, the confirmed, the negatives, managing their babies, supporting breastfeeding, and so on and so forth. So just in the last 20 days, we've had around 412 deliveries, 125 plus mothers tested positive, and we tested their babies. So 125 babies were tested. 10 out of these tested positive. 7 of them were in the birth admission. 2 babies had gone home with the mother, came back for some maternal problems. 1 baby was admitted for some feeding issues, and they were positive. However, all of them asymptomatic. So we continued to keep the babies with the mother, tested them again on day 5. If negative, they were discharged. 2 babies continued to test positive even on day 5, and 4 babies are still awaiting their day 5 testing report. We've managed to have a telephonic follow-up for about 50 of these mother-baby dyads. The rest will be followed in due course of time. And it's very heartening to know that all of them are exclusively breastfeeding. So what exactly did we start doing? So if we had a woman presenting to us in labor, we would check if she resides in the hotspot or containment zone. And there is a huge number of these women coming into the hospital at present. If not, she did not require any testing and she received all the routine management. If yes, the testing was done. However, the report takes around 12 to 24 hours to come in. So she also undergoes the routine management, but we would hold her in a separate holding area, keep the baby and mother together, start breastfeeding, provide all the routine care. While doing this, it was important that use of PPE was started in all the labor area. Mother was counseled, each and every mother was counseled to maintain respiratory and hand hygiene. The moderate to severely symptomatic mothers were transferred to the medical ward, and this number has been really, really negligible. And her baby would be shifted to the holding area in the NICU. Now, in the holding area, once the mother's report was available, we separated the negative mothers out into the routine PNC, and the positive mothers were moved into a COVID PNC area. We continued to keep the baby and mother together. Breastfeeding continued, respiratory hygiene, hand hygiene was explained, and we sent a baby swab at 24 to 48 hours immediately after we got the mother's report. If the baby tested negative, again a mother and baby kept together. She's counseled about maintaining respiratory hand hygiene, and the baby is discharged as per routine protocols. If the baby tested positive, the baby was monitored for symptoms related to COVID, and we planned that if we did find a baby turning symptomatic for an influenza-like illness, we would shift this baby to the pediatric and neonatal common isolation area. But by God's good grace, we've had none of these 10 babies has had any symptoms of influenza-like illness. If no symptoms of COVID, the baby and the mother continue to stay together like any other normal baby mother, but with respiratory hygiene, hand hygiene reinforced. Routine problems were managed in the postnatal ward, so jaundice, feeding issues, lactation counseling was provided in these areas, and a repeat test was done on day 5. If negative, again baby sent home. Positive, we plan to repeat on day 10, and then if positive, again if the baby is asymptomatic till day 10 but positive, the plan is to send the baby home irrespective of the status. So far we've not reached, and no baby has reached day 10 with a positive report, so still waiting to find out what's happening. And telephonic follow-up is being done and planned for all these positive mothers who are going home, and we are providing telephonic counseling and trying to coordinate a follow-up if there is a need. The NICU, again, we have a very busy NICU, and having babies being delivered to suspect mothers, positive mothers, negative mothers created quite a big confusion in the NICU also. So we created a separate holding area in the NICU, and all the routine management was continued. Babies were fed expressed breast milk if the mother could express and send her milk. Those who could not send her milk, we fed their babies pasteurized donor milk. If the mother tested negative, we would shift the baby out into the clean NICU. If the mother tested positive, then the baby was tested just like the other babies. If the baby tested negative, again the baby would be shifted out to the clean NICU. If the baby did test positive, and in the NICU so far we've not had any single baby test positive, the plan is to manage whatever neonatal complaints that the baby has, and manage all of these in the COVID isolation area, which is common for pediatric and neonatal patients. Extramural babies who get referred after birth with suspicious symptoms, they're all admitted to the holding area and tested, and those with suspicious symptoms, still no one has really turned positive, and I'm really glad about that. So if we do have a mother who does come with a positive report, we have the luxury of actually referring her to the dedicated COVID hospital in the city, which is a tertiary level hospital. So she gets antenatal care, delivery at Nair Hospital in Mumbai. And then since all the mothers are positive, they follow the standard protocols for all of them. They've not really had the trouble of segregating them into different sections. So skin to skin contact, bedding in, breastfeeding going on. Mothers are allowed to enter the NICU after they are swab negative. They can handle their newborns, express milk, feed their babies with all due precautions. However, kangaroo mother care is a big challenge there. Over 100 COVID mothers have delivered in the dedicated COVID hospital as well, and they are yet to report a positive neonatal case. So lots of challenges when we were handling such a mixed group of patients coming in. Right from the antenatal period where we had decreased visits, so counseling was limited, travel was limited, the lockdown is very, very strict in Mumbai and the surrounding areas. Uh, After delivery, skin to skin contact, postnatal counseling again is suboptimal because staff attendance is suboptimal because of travel problems in the lockdown. And then they have to be, they're all put in the COVID areas for duties. And so there's a lot of shuffling of duties of the staff as well. In the NICU, suspect and positive mothers cannot be allowed. And the other problem with allowing the negative mothers is they come into the unit, they crowd the unit, and then there was no social distancing. So that was a big issue. So currently we have stopped entry of mothers into the level 3 area. However, we do allow them to go into the premature and convalescent unit, which is a little more roomy and settled. Again, kangaroo mother care is challenging because of overcrowding, difficulty in maintaining social distancing if too many mothers enter the unit at one time. Post-discharge follow-ups are difficult because of travel problems, home visits are not possible, and the high workload, overburdened staff, overburdened doctors is making things very, very challenging at the hospital. Again, because the nurses and the servants are forced to work in COVID and non-COVID areas, otherwise staffing all areas becomes a big problem. Few of them have started testing positive, and the absenteeism is really prolonged till they turn negative and then go into quarantine and come back. So that's another issue which is coming up, and it's only going to get worse in the times to come. And in the hot, humid climate of Mumbai, it is so difficult to wear PPE and sustain for 6 to 8 days. It's really, really difficult to work in the PPE. And now with the latest ICMR policy, which has been published on Monday, the 18th, where testing has become more restrictive, we really don't know how which mother is positive but not tested, but she's still with the common group of mothers in the postnatal ward. So this is only going to make things more challenging, and I hope we are able to overcome this challenge as well.
Okay.
Milk bank, yes, that's just half a minute. Milk banking is also pretty much affected because we are encouraging breastfeeding and hand expression whenever required. Counseling services are being provided to mothers irrespective of their status. Pasteurized donor milk is used for feeding high-risk babies. However, the policy has become very restrictive because collections are remarkably low. OPD-based collections are virtually zero. IPD-based collections have also dwindled remarkably because we are not collecting from positive mothers, we are not collecting from suspect mothers. So the pool of negative mothers is very limited. And again, the staff shortage is the other issue which we have. So there's a big problem that we are now faced with, at least in the milk bank, that can we recruit the COVID positive asymptomatics? Can we recruit asymptomatics who really don't have a report and will not be tested? Can they donate immediately after they are swab negative? How long do we need to wait? What about longitudinal donors? What about OPD donors? What about sterilizations? Reuse of lactocytes? Do we really understand that human milk is safe, or do we still need to have more testing because it's a mutating virus? We don't know whether the strain is the same in Mumbai, in Delhi, in Rajasthan, in the other parts of the country. And can we start look at the antibody testing, IgG, IgM as a screening criteria, just like we do for HIV? Does that give us some advantage when we are not going to get a nasal swab? So lots of questions in my mind, and I'm looking forward to some answers in this webinar. Thank you so much.
Thank you, Dr. Swati. I think you are. But looking at Dr. Swati's and Dr. Sushma's talk, I think it is very, very positive, and I think we are quite comfortable and probably finding that our newborns are not generally getting affected by this COVID positive mothers. And I think the health sector and the administration should at least look at it, that how cost effective it is to have separate issues for this, and can we have much more liberal guidelines to ensure that milk banks start surviving again, because even my milk bank is now dwindling with milk, and we have to have those things into consideration, uh, especially if proper pasteurization can be done in all these asymptomatic mothers who have not been tested at all. So that's the question. We'll quickly go on to Daniela from Brazil, and she's a food technologist and a very ardent fan who wants the whole, who represents the institution of Firecruz along with Dr. Jaw, and who have been the leaders in human milk banking, and who have the philosophy of milk to every newborn. And that is a great philosophy, I must say. And with the technical cooperation being extended to 25 countries, I'm sure Daniela can give us some of her experiences with her own country and with her country she has been interacting. Daniela.
Okay, sorry. I would like to thank you the invitation to be here. I'm very glad. And I begin my presentation. So everybody hear me now? It's okay? And sorry about my bad English, okay? Well, let me put full screen.
Your English is very good, Daniela.
Oh, thank you, you are lovely. The Brazilian Network of Human Milk Bank is an initiative of the Ministry of Health of Brazil, together at the National Institute of Women, Children and Adolescents Health, Fernandes Figueira, that is a maternal and child health center of Oswaldo Cruz Foundation, also known as Fiocruz, like Dr. Sitaraman said. So Fiocruz is responsible for public health research in Brazil, and which encourages support the Human Milk Bank network doing research and technological development in the area of breastfeeding and human milk banks. 2 days ago, we celebrated the World Day of Woman Milk Donation with a network of 223 human milk banks and also 215 collection points that support, promote, and protect breastfeeding for low-weight newborn in neonatal units. Because the number of human milk banks around our Brazil, we still celebrating this day. We're gonna celebrate this date till the end of May. Every day we have a conferences of one of the 27 states of Brazil. This year, like everyone else that we can see here, this network faces a new challenge: how to continue and promote, support, and protect breastfeeding and the donation of human milk bank in the context of the COVID-19 pandemic. Well, once in a month, the Brazilian Network of Human Milk Banks meet by teleconference to discuss scientific topics, protocols, plan festive dates like the donation day. But in March of this year, the network met to discuss existing acknowledgements about breastfeeding and COVID-19 and decided on an extra session to revisit the Human Milk Bank technical standards in order to check if our understanding of good practices are effective or not to fight against the COVID and prevent from it. So when the Brazilian begins the infection, we put all member of this network, all member of these 223 human milk banks and the 215 collection posts to discuss what happens in the world and what will happen in Brazil and how to protect against this, how to fight against the COVID. Well, to explain a little more about our network, all human milk bank professionals has a specific training for the area of processing and quality control, carried out by a distance learning platform that consists in 21 topics ranging from the history of the Brazilian network of human milk banks to the global network, composition of human milk, physical chemical changes in human milk, clinical use, in addition to description of the process flow and technical standards for each step of this flow. From the selection of the donor, of the liver of the pasteurized milk products, all professionals having taken this course is a prerequisite for beginning work at the human milk bank. The training of human resources in Brazilian network in the global human milk network is one of the criteria of the quality certification program of this network. So if you are a nurse, if you are a technician, a nursing, if you are a nutrition, you are a health professional that wants to work in a human milk bank in Brazil, you have to be inside this platform to know more, to learn more about the product, about the process, about the way that we work, about our history. And inside of the platform, you can see these standards and our recommendations. So I would like to present to you the entry screen of the course on process and quality control of human milk bank. Just wait a minute back to here. Here. This is the open window, open screen of the course. This is the picture of the last meeting of the global network. We can see all countries that make part of the global network. Back to the course. So here you can see all topics that the people gonna study, and this is our flow. Each box of this represents part of the process that the human milk goes through, and there is anything in the course that's provided: definition, principle, good practice, in short, what to do, how to do, doing it safely. So let's take an example here. The topic 7 is about sanitary obtaining of human milk bank. Secure way to express the milk, the human milk. How to perform the extraction of milk following the biosafety criteria. Remember that process must be safe for women, for health professionals, and for premature infants. When you open the topic, you can see a lot of reference of these, and this time brings in theoretical framework the organization of the human milk bank, the human researchers that gonna do this process, the infrastructure that you need to do this process, the equipment, the instruments that you need, hygiene, way of do this, and the process, the cleaning of the equipments that you do, how to transport, if you need to transport, how you identify the product, and how important is the code way that you have to do. Oops. So COVID brought to the concern of hygiene care, personal contact. The Brazilian network has guidelines for hygiene of professionals, donor, and environments, which point out the importance of cleaning hands and forearms with water and soap, alcohol gel, and the use of security individual protection equipment. So what I told you, when you do the course by platform, you have information, we have scientific reference, and you can access the guidelines of our network, the technological standards. And I show some ones here to you. This is for cleaning ambience. And in this meeting that I told you that we did at March, we discussed one by one. This is the 7th one that said how cleaning and disinfection the human milk bank. So we do this for a long time. This is not create today. We have almost 4 years of history. In the beginning of the 80s, we construct these criteria. To guarantee the technical standards that the health professional becomes aware of during training work in a human milk bank. They are available on the network website. This set of technical standards are now that were revised by Human Milk Banks of Brazil in a web conference. Recalling that the objective of web conference held in early of March, when Brazil didn't have even 10 cases of infect people, this network come together to review the good practice for handling human milk applied in milk banks. And this group comes to the conclusion that the standards are based on all biosafety criteria. They are still sufficient to keep safe donor, professionals, and premature babies. Another one is the same hygiene and way to work of employers, of professionals, and of donors. And we still, since the 80s, put the criteria that we really want now. Use the hygiene personal practices and using the security individual protection equipment. Remember that in the 80s, when the world experienced of IgV epidemic, many milk banks were closed. Here in Brazil, we proved that our process was safe and that pasteurization carried out inactivated the HIV virus and were able to follow our history. The same today, the pasteurization is able to inactivate the COVID like Rutica present for us. Another one, how to transport the human milk for the home of mother, the donor, to the human milk bank. And we do this, we still doing the household collection, and this is what permits that keep the volume of donated milk since the mothers could not go to the hospital. So we don't have problem with the volume, the recollected volume in the COVID time, because we're still doing the household collection. And we have a standard to receive the milk from the home of the mother as well, the donor. And finally, pasteurization that guarantees the thermal inactivation of pathogenic bacteria were independent of a pandemic time. The care and control of entire process is carried out in bottles in all pasteurization, in all bottles, in all pasteurization beds. And I would also like to remind you that the Brazilian network carries out a dynamic quality control based on the principles of HACCP and static final quality control. This meeting, what I told you, take place with all networks that integrate the global network, Brazilian, Ibero-America, and community of Portuguese-speaking countries. So I show there are videos available in our network as well. We have a part of the page, the web page, with the Global Human Milk Bank Network against COVID. And so the first one is when we discuss breastfeeding. The second one where we discuss the good practice in the human milk banks. And the other one is Colombia and El Salvador. And we did the same with all countries of Ibero-America, with Africa, with other countries to discuss it. And by these discussions, we sign some recommendations about breastfeeding, donor milk, and breastfeeding care that also available in our page. And at this moment, with information to donors and to the professionals of this network, keeping home collection of donation at the first month, we had better collection volume that allowed us to remain stable since last week. But I know that next week our volume will get even better because the donation day. 2 days ago, we celebrated the World Donation Day. And like I said, the Human Milk Bank is a policy of Ministry of Health. So there is a campaign, a merchandising did of the Ministry of Health policy. I have time to show the video. Dr. Citron, I have time.
I will see at the end of the sessions. I just don't know.
Yeah, it's just a few.
How long is it?
Just a minute, few minutes.
Okay. And Daniel, a quick question. I think you have presumed by your presentation that you have, by pasteurization, your COVID, this thing would be negative, isn't it? Are we on?
So,
It's not logging in.
so this is what the Ministry of Health do for us of the Human Milk Bank Global Network. He did done the film, this small film that invite the woman that produce milk be a donor. folders and posts to share in the internet. So this is all for the people who work in the Human Milk Bank. And in this year, the celebration, it's all because the pandemic problems, it's all
I think
doing
the
by
video is not
internet.
visible, Daniel.
What, doctor?
Are you running the video? We can't see the video.
Oh, no.
Okay.
Well, let me check here again. So
Can't
I
see it.
close the video.
You have to close your screen for presentation.
Danelia, you need to stop sharing your screen first and then show the video. The screen is still showing your presentation.
Okay, thank you.
Yes. Yeah. Now you can showcase. Yeah.
So let's begin again. In the last months, do you, oops. So this is the campaign of Ministry of Health that come together with posts, folders, and they send these to all human milk banks, and you can use it the way that you want. And this year, because the pandemic, we are celebrating everything by the web conference, webinars, lives, and promoting and the challenges in the internet. And the surprise for us, working with information for all areas, donors, professionals, and mother of premature babies. The network get better in the recollection volume of Human Milk Bank. So thank you, everybody. We finished.
And thank you so much for your contribution to this webinar. But a quick question before, I'm not sure whether you are going to stay on to the whole session. You have presumed or you have accepted that the pasteurization will remove the COVID virus from your pasteurization process, and you accept all mothers whether she may be asymptomatic positive. Is it?
No, when we all week are in contact of the mothers of the donors, and when a donor said to us, I have the symptoms of COVID, we stop the donation for the very period, 14 days.
But you have community collections, isn't it? So if there is a community spread in the country,
yeah.
how do you prevent the collection from homes where mother may or may not be tested for the same? Whether
we don't test our mother. We don't test the mothers for COVID. Even Brazil doesn't has a lot of tests, and we use the security, individual security equipment for all employer and orientation for the mothers. We don't get into the home of the mother. We at the door, respecting the the geographic distance, we take the bottles. We take a full bottles and let sterilized bottles empty to continue the process. But during the week, if we ask the mother, okay, how are you? You have milk to donate? And she said, oh, I have throat problems, I have fever. Okay, mother, we continue calling to check your health, but we don't go to your home this week.
Okay.
Next week, we check again. It's a health program.
So if you feel that the person, mother has got some infection or she is running temperature or fever, you are not going to collect the milk from her. Otherwise, you are going to collect the milk from her. Isn't it?
Yeah. Yeah.
Okay.
And
thanks a lot, Daniel.
Yeah, I would like to thank you, everybody. Again, apologizes for my bad English.
That is absolutely fine. We all understood you, you know. So
I'm gonna back to my English class, and I feel sorry, but I have to go because we have another conference in Brazil. But pleasure to meet you all.
Thanks a lot for participation, you and Dr. John. We have not heard him, but we know he's been around there somewhere. Yeah. Yeah. Okay,
Thank you.
Take care.
Very nice.
We quickly move on to Dr. Gillian, who is an international human milk bank expert and who has more than 30 years of experience. And I'm quite sure her experience of sharing her viewpoint from European countries would tell us whether the guidelines could be put to practice at the ground level. Dr. Gillian Weaver, you're welcome to address.
Thank you. Hi. First of all, let me check that everybody can hear me. Yes?
Yeah, it's okay.
Okay, thank you. And I think one of your colleagues is going to share my slides because I had a technical failure here. So I had to use my telephone. They're being shared. They're coming up. Thank you for promoting me to a doctor, but I'm not a doctor. I will just point that out. So everyone knows, but I appreciate that. Thank you also for your very kind invitation. It's very nice to join you here, and I'd like to say good evening to everybody. If our Brazilian colleagues are still there, well, good morning to them. Okay, so if you can open up the next slide, please. So let me tell you that my brief is to talk in these challenging times how we can ensure optimal antenatal care, breastfeeding, human milk feeding in the NICU, early skin-to-skin contact, rooming in, bedding in, and so on, collection and supply of donor milk, kangaroo mother care, discharge and follow-up services. And you gave me 8 minutes, so I decided I'd better cut those down. So the next slide shows that I'm going to really just talk about some of the feeding issues. Can you move the slide on, please? I'll just talk about some of the feeding issues, and particularly about donor human milk. So again, moving to the next slide. In the UK, we, like many countries, we rely on advice and recommendations from the Baby Friendly Initiative. So in the case of the UK, the UNICEF UK Baby Friendly Initiative have provided for some time now some very helpful statements and guidance sheets, and also education refresher sheets, and these are freely available to everybody. And I think that this has been greatly helpful, that these were based on WHO guidance, but also on expertise from both within and without the UK. And these are available on the websites. Perhaps I should say to everybody that I'm very happy to make a PDF of this presentation available. So you will have all the links that are in this presentation. I'll also add in some extra photographs to be able to illustrate some of the things that I'm saying. I had to email this, so I couldn't have too many photographs in it. But if we go on to the next slide, the other thing that's there on the Baby Friendly website is a lot of frequently asked questions, and these get updated. If you can move on, if these get updated as new evidence emerges. There's a whole series of questions that are really helpful, I think, for everybody working in the field, but also for families as well. But yeah, so you can see these are the sort of questions that are there for what do healthcare professionals need to discuss with pregnant mothers, answers to questions, the obvious questions like, can women with COVID-19 breastfeed? Can parents touch and hold their baby? The sort of questions that all parents will want answers to. And the answers are all here. So just going on to the next slide, there's more questions about that parents might ask about, is it safe to use donor human milk? And our colleagues as well would ask that. Is sharing breast milk informally safe? Should mothers and babies be separated, and so on. So lots of questions that are there that get updated. And if you could just please go on to the next slide. I'm going to go through these quite quickly because, as I said, you'll be able to access these this presentation and be able to read all the answers. But just to say that, of course, the ideal is that there should be the opportunity for an antenatal discussion with all mothers about the value of breast milk, particularly during this outbreak, and also how to get breastfeeding off to the best start and the importance of skin-to-skin contact. So we would hope that all mothers would be having that conversation. Throughout the UK, I think the antenatal care pathway is pretty similar, and there have had to be changes due to this pandemic. So appointments are now far more often than before would be done over the telephone, or we've discovered online appointments. There are much fewer face-to-face interactions with midwives, nurses, and so on. Partly because of reduced staff levels, because of people having to either stay at home because they're unwell or isolate because they're in contact with the infection. And so parent craft classes, which are so important in terms of breastfeeding support and education for new parents, have had to become online. And of course, that excludes anybody who doesn't have the facilities to be able to take part in them. So if we could just go on to the next one. The answer, of course, is yes, but there's some explanations here. And if we can we'll just keep moving through these slides, please, because as I said, everybody will be able to read them. A lot of the things on these slides have already been discussed this morning, or this evening. So yes, we can go on about newborn babies. There's practical information that's provided by the UK governments and also WHO, which is readily available to everyone. So moving on to the next one about what if a mother's too unwell. There's talk about expressing and feeding the expressed milk via an alternative method. But also very importantly, to ensure that if breastfeeding hasn't gone well or hasn't been established well because of the circumstances, that there will be encouraged skin-to-skin contact and return to full breastfeeding as soon as it's possible. So not to give up on mums because of struggles. So moving on to the next one, which was question number 7. This is an important one for us in the context of milk banks and donor human milk. Is it safe to use? And of course, now we would say definitely yes. But when the pandemic was first reaching our shores, there were question marks about this, and we still have some question marks. You were asking some there, Dr. Sitterman, about are we certain that pasteurization inactivates the virus, for example? So I think one of the great things here was that the recommendation is that donor human milk should be used in the right circumstances. They have links on the baby friendly on the UNICEF website to guidelines that are used in the UK, but also to guidance from the European Milk Bank Association, from UCAM, which is the UK Association, which also has guidance for mothers who are wanting to donate and for families whose babies might be being offered donor milk, and the Hearts Milk Bank that I'm very closely involved with also produces information sheets as well. So going on to the next slide. Informal breast milk sharing. There's a lot of informal sharing in the UK, and this is definitely not recommended, especially at this time, because of the potential problems of infection through close contact or through the virus on surfaces. Going on to the next slide. Advising against separation, and the next one is encouraging expressing, of course, on the neonatal unit, or if there's separation. If you can move on, please. So, and again, we would want mums to be supported in the same way that we always would do, to be able to express, as long as mums are well, that they should be able to express, ideally within a couple of hours of delivery, and expressing 8 to 10 times thereafter, including at night time. So breast milk obviously essential for these babies. If we can go on to the next slide. Thank you. So this is a crucial one. The one before was about where mothers have suspected or COVID, and what about if their baby is on the neonatal unit. So, I mean, this is a really tragic situation for parents to be separated from their baby who is sick or has been born with a very low birth weight or premature. And so being able to support them in lots of ways to try and mitigate that situation, to be able to ensure that they get pictures, that they get videos, that they get constant contact as much as is possible with heavy staffing responsibilities at the moment, and definitely that where there isn't enough or any of the mum's own milk, that donor milk is the second choice. So yes, if you can go on to the next slide again, please. So this tells you in practice, and this is the sort of guidance that comes from WHO, that this is what you would do if the mum has COVID-19. So this is available and would be used throughout the UK. However, it does differ from some of the advice that, or some of the procedures that were being followed in other countries. If you go on to the next slide. And indeed, initially, in the very first instances, we were very concerned because there was suggestion that babies wouldn't be able to receive their own mum's milk or to breastfeed. That was the case in some countries in Eastern Europe. But once there was more evidence available, and once they saw that the recommendations that were coming from other countries, this got changed. There's some links here to other sets of guidance, and thank you. The next slide talks about what EMBA has been doing. EMBA is the European Milk Bank Association. We represent 248 milk banks in, I've forgotten how many countries. I think it's 30 odd countries now. But EMBA came out with a position statement quite early on in February, towards the end of February. And on the website, we have also been posting and keeping a record of papers, any evidence that has been reviewed, commentaries are posted also on these. And if you go on to the next slide, you will see that we created a task force specifically looking at all aspects of recommendations to do with human milk banking specifically, but also to do with feeding infants on the neonatal unit. This is available. You can freely access all the information here. Thank you. And one of the first papers that was uploaded in April was from Italy, from the Italian Society on Neonatology. And of course, in Europe, Italy was the first country to be really hit hard by COVID. It spread very quickly. Their hospitals came under enormous pressure, and there wasn't at the time that they were first facing it a lot of expertise to draw on. So these recommendations were very important and were used throughout Europe. They were also endorsed by the Union of European Neonatal and Perinatal Societies. So if we can go on, the Heart's Milk Bank very quickly published some advice for human milk donors, because we want mothers to donate their milk, but lots of mothers would be asking questions about whether it's safe to do so, what are the practicalities, what are the challenges, and of course we were aware that there were going to be a lot of challenges coming in between mothers being able to donate milk. So some new challenges. So for example, we needed to think about the extra precautions that were needed in the milk bank. In the UK, as in most of Europe, most milk donors are mums in the community, and they, once recruited, they express and store milk, sometimes for several months or longer. And once they are fully screened and they've been fully recruited, they will then collect the milk at home and store it at home. So this brought extra challenges, because we needed to think about how the milk could be transported safely. Throughout the UK, it's mostly transported by volunteers, and so we needed to be very careful about the safety and the health of our volunteers. We developed contactless collections. We also worked, one of the nice things was that we were able to work much more collectively with all the milk banks throughout the UK. There are 14 milk banks, and milk gets collected over quite big distances. So for example, in Scotland, there's one milk bank that provides donor milk to all the hospital neonatal units throughout the country. And in England, there are several milk banks that provide donor milk to at least 30 hospitals. So this service, we had to work quickly to make sure that this service wasn't compromised. The other problem for us was that all donors have to have a blood test at the time that they become a donor, and mothers usually go to their family physician services to have the blood test done, and this was no longer available to them, because they weren't offering these services anymore. And it meant that we were concerned that we would become short of milk as a result of not being able to screen the donors. We worked together with all our colleagues in all the milk banks around the country, and we kind of worked out what would be the best means of supporting each other if any milk banks ran out of milk. I was listening to some of the earlier talks where you were saying that you were very worried about running out of milk. One of the things that we did was work together to ensure that we could support each other so that hospitals wouldn't run out. So if I can go on to the next slide, please.
We have 1 more minute, Gillian.
That's just about the time I need, thank you. So, the other thing, kind of spreading this, so worked, obviously collaborated through EMBA with milk bank leaders throughout the whole of Europe, but it also became very obvious to us that there needed to be a much more wider sort of collaboration, the means of being able to share information. And so I set up a virtual communication network using WhatsApp that currently has about 80 members from 36 countries. And we were able to share our concerns, share our challenges, but also share our solutions. And I think that was very useful. It meant that very soon we were able to put together, coordinated by Dr. Schenker, who I think is on this call still, a commentary piece that was published in The Lancet recently at the beginning of the month, and the link is there for you to read it. We worked out that there's probably about 800,000 babies at least globally that receive donor milk each year. So this is a huge problem if milk banks are suffering and not able to provide a safe service. We wanted to be able to provide a call to action to policymakers, to WHO and so on, to be able to support and look at how best to support milk banks. The map there is posted on Lacta Hub. It's the map is part of the PATH resource toolkit. And so this has worked successfully, and I'm hoping that we will be able to turn it into an official global alliance of milk banks and associations. These are the conclusions from that paper, that SARS coronavirus 2 isn't transmitted vertically through breastfeeding or human milk, that it is inactivated by cold pasteurization, and that human milk bank services should be supported, but also donor milk should be used for as short a time as possible. If you can carry on to the last slide, those were the conclusions, and then the very last one is here. As Danielle, the next one, please. As Danielle was saying, 2 days ago, globally, we celebrated the World Day of Human Milk Donation. The theme, in common with Brazil and all of the Portuguese-speaking countries, was that every drop makes a difference. Can you go to the final slide, please? And I do hope that you will go to the link here. There's a video, and there's also a lovely photo album with hugely inspirational messages, about 150 of them from all over the world, showing that together we are a global human milk bank movement, and we can work together to make things better. Thank you.
Thank you. Brilliant, very lucid presentation, Gillian. Kulik, just think that we are on the two extremes, that technically Brazil is following all those mothers. If they are not keeping well, they don't take the milk. On the other hand, we have Gillian's viewpoint, where they test the mothers before they collect the milk. So where are we?
Wait.
No,
can I just interrupt? We don't test for COVID, no. So I'm sorry, I didn't make that clear. The blood tests are for HIV and hepatitis and so on. So no, we don't. No, we don't. What we do is, before we collect milk, we talk to the mothers. We contact them by telephone or online, and they have to declare that they have been well, that they've had no symptoms, and that they have had no known contacts. The milk is collected contactless, and then once it arrives in the milk bank, this does differ slightly between milk banks in the UK, but most will quarantine it for 2 weeks. So it will go into a holding freezer for 2 weeks, and then before we do anything with it, before we pasteurize it, we contact the mother again to make sure that her health status is the same. We also take precautions to make sure that there's no possibility of transmission of infection via the containers, the bags, everything is double bagged, and we did a lot of training, and we developed SOPs for the couriers, as well as new ones for the milk bank staff. So no, we don't do testing. It's nigh on impossible to get, or it was until recently, to get tested. Even if you, for any reason in the UK, we've been very lax on testing.
Wonderful. I think that may be a way out for our situation also. And now we quickly go on to Dr. Ajay Kheda, and it's a long-awaited thing, because after all the discussions from our international national group and the guidelines and the ground level work, I'm quite sure that his experience of 25 years of telling the MCH and handling all the situations and so many outbreaks of other kinds, he should be able to guide us into how we should proceed. And also, since he has listened to all of us, and I'm quite sure he would have modified some of the issues he is going to address today. Dr. Ajay Kheda from the Commissioner of Health from the Ministry of Health. Today. Sir, please welcome.
Very good afternoon to all of you. And thank you, Dr. Sitaraman, for my introduction. Now, I have been asked to make a presentation on what are those, the policy perspectives in the context of MNCH services in this COVID environment. As you know that the COVID pandemic in India is evolving on a daily basis. And we also know that in India, a large number of districts are still, they have not reported even a single case of COVID infection. So it's quite, kind of a patchy situation. And I call it as an evolving pandemic in India. And even the guidelines which have been prepared, they're also evolving on a daily basis. And the guidelines which I am going to present to you now, which has been developed looking at this evolving pandemic and also by consulting various experts and looking at the operational feasibility of implementing those guidelines. So I will share those guidelines. I won't take much time. I know that we are already, I think, overshot the time, but I will try to be concise as possible and I will try to, minimize the repetitions. Can I have my slides now? So I am going to talk about these guidelines which have been developed for the RMNCH services by the Ministry of Health. Next slide. Now the government of India has, made a kind of issued the notification that they have identified some services as essential health services. And luckily, even the RMNCH services have also been declared as the essential health services and they have to be delivered. And I think when Ruchika was making a mention that if the coverage of variety of interventions get disrupted, whatever gains we have achieved in terms of maternal and child health outcomes, they will all be defeated. So that's why the government of India said that essential health services have been identified and they have to be delivered. And all those services, they refer to the RMNCH arena, which also include pregnancy care and management. And then beside that, there's a newborn care and adolescent health services and management of SAM children. Next slide. Now, in India in particular, I have just made a mention that districts have been categorized into the green zone and the red and the orange zone. And there are a number of districts which are called as the green zones, which have not reported a single case of COVID. And within the red and orange zones, districts have been further classified as containment zone and a buffer zone, and then the areas beyond buffer zone. I think if you look at the right side of the slide, it depicts the area of the containment zone and the buffer zone. Now, what has been done in our policy guidance that the services, RMNCH services, they have been bifurcated into the services in the containment and the buffer zone, and then the areas beyond buffer zone and the green zone. So the guidance will be based on this kind of a classification. Next slide. Next slide, please. Now, these are some of those guiding principles which have already been talked about, but I'll quickly run through for the purpose of completing the presentation that whatever guidelines they are available, they are updates from the Ministry of Home Affairs and the Health and Family Welfare, they will override any other guidelines. And there is any area exiting a containment zone can start RMNCH activities as listed in areas beyond buffer zone after a gap of 14 days of following delisting. And similarly, any area exiting beyond buffer zone should start RMNCH plus and activities immediately as outlined in the containment buffer zone. And I'll detail out these, what are those guidance, but this is as a broader principle. And we are also, promoting the private sector engagement, not for profit, to be involved in the provision of the non-COVID essential services, wherever the public sector capacity needs to be supported. Why I'm making a mention of this point is that across the country, we have identified around 700 odd dedicated COVID hospital. We have identified dedicated around 2,000 dedicated COVID health centers, where only the people with the COVID positive status are going to be admitted. But there are large number of places where non-COVID services needs to be provided. So we are encouraging private sector and the not-for-profit to participate. And then the basic concept of practices of physical distancing, hand washing, respiratory hygiene need to be maintained in all service areas by all beneficiaries as well as the service provider. And facilities should follow while providing so-called the essential services a staggered approach, and wherein adequate seating space for beneficiaries and caregiver with the physical distancing is ensured. Because the whole RMNCH services, they are not only provided in the facilities, they are also provided in the community as well, because large number of antenatal services are provided in the field. And we have the VHSNDs that are in the community. And even we also made a recommendation that there should be limited participation at a time and even following the staggered approach. The next slide. Can I have the next slide, please? Now the guiding, the principles further, that the procedure, the site and all equipment should be sanitized properly before and after the clinic and the sessions. And the healthcare providers are also important. They are the critical component during this COVID pandemic. They have to use appropriate PPE, and the government of India is providing adequate amount of PPE across the country. But the important message is that the critical services for women, children and adolescents should be provided irrespective of their COVID status. Why I'm making a mention of this point is because at some of those places we notice that people are asking for COVID testing before providing any essential critical services. So the government of India made a very categorical statement that irrespective of the COVID status, these critical services needs to be provided. And we have, I told you that we have 600 odd dedicated hospitals. We have 2,000 odd dedicated COVID health centers. So all suspected COVID cases and confirmed cases should be preferably be provided services at the dedicated facilities. And the routine COVID testing is not mandatory for provision of RMNC services. We are also, giving a lot of emphasis on teleconsultation so as to encourage physical distancing. This is being promoted at all levels to prevent overcrowding and reduce cross-infection. And even the drugs, commodities needed for continuing RCH services should also be treated as the essential commodity. Because capacity building is one of the integral component, and even the reviews, they have to be carried out preferably using the digital health platforms. And under no circumstances should there be a denial of essential services. Next slide. Now, in terms of the specific the maternal health, now the suggestion given in the policy is that every pregnant woman is to be linked with the appropriate nearby health facility for delivery, and even the ambulance services also to be tied up for timely transport. This is critical and important because now at this point of time we have more than 80% deliveries happening in the institutions. Because of this COVID, we do not want that institutional delivery to be converted into a home delivery. That's why this special message, special guidance has been given. Now, in terms of feeding and the nutrition and the breastfeeding in particular, mother and the baby to be nursed together as far as possible, and the breastfeeding to be initiated within 1 hour of the delivery, irrespective of the COVID status. Because there was some confusion. I was looking at the pooling which you did. I could find 36% separation was being followed. So I think here the categorical statement which is being made based on the available evidence as on today, that irrespective of the COVID status, mother and baby should be together, breastfeeding to be initiated within 1 hour, And however, she should put on a face mask, practice hand hygiene, before each feeding. So at least, she can take those kind of precautions. The next slide. And similarly for the area of adolescent health, next slide. To address, the anxiety, next slide. For adolescent health, can I have the next slide? Next slide, please. So adolescent health, to address anxiety and psychosocial issues among adolescents, there is a lot of emphasis on peer-based counseling, teleconsultation, and even the government of India has also come up with the helpline. Similarly, for family planning, there is a guidance in terms of continuing to provide comprehensive services. And then there are specific guidance in terms of the campaign mode services. That most of those campaigns which were happening in the country, like we have the Mission Indradhanush, we have the mass vitamin A prophylaxis, and even the diarrhea control fortnights, they have all been suggested that we suspend them for the time being, but based on the local situation, alternative mechanism can be decided. Next slide. Now, in terms of, the specific guidance, in terms of, the antenatal services for containment zone and the beyond buffer zone. The point which I want to mention here is that in antenatal services, there is something called as the PMSMA, Pradhan Mantri Surakshit Matritva Abhiyan. Now, we have suspended this PMSMA in the containment and the buffer zone. But beyond buffer zone, PMSMA to be continued. And we said that in containment zones, there will be limited ANC services because the movement of the people is restricted. But if somebody walk in to the clinics, to the facility, services needs to be provided. And the containment in the buffer zone will not have the VHSND, or in the urban areas, the so-called the UHSND. But beyond buffer zone and the green zone, we are talking about something called as the modified VHSND, where 5 to 10 people are together in terms of provision of the services. Now, in terms of the delivery services, they need to be provided at all health facilities. But the important point to note is in terms of birth companion. Birth companion as an intervention which was started, and the recommendations are that the birth companion is to be avoided during the delivery, because we want to minimize the overcrowding. We want to maintain that physical distance, at least in the containment and the buffer zone. And even beyond buffer zone also, we said birth companion is to be avoided. Post-natal care through teleconsultation, but in the green zone, uninterrupted PNC services needs to be provided. And also, there is a next slide. Now, this is critical and important, particularly in the context of the newborn care. Now, in terms of the newborn care, there are two types of zone: beyond buffer zone and the green zone. All services as per the guidelines. But the important point to note in terms of containment and the buffer zone, that the services to the sick newborn, irrespective of the COVID status, is to be provided to the nearest SNCU by ensuring proper referral arrangement. And the routine SNCU follow-up through teleconsultation. However, sick newborn showing danger sign to be referred to the nearest SNCU. Because it is not possible to have a dedicated SNCU. So what we are suggesting is that the nearest SNCU may have some kind of an isolated facility where care of the positive neonate, the neonates, positive sick newborn, or the sick newborn born to a positive mother can be managed. But the important point to note is that the family participatory care in the SNCU is to be suspended for the time being. That is the suggestion given. And then in terms of the home-based care and the home young child care, which is very critical intervention in terms of promoting breastfeeding, promoting child feeding breast practices. In that buffer zone and the green zone, these services need to be continued. But in the containment and the buffer zone, these services needs to be continued using the mechanism of teleconsultation. Next slide. And the last slide is in terms of the RBSK program and the management of children with the complications which are being admitted at the NRCs. No, we said in terms of the management of the SAM children to be provided to the in the nearest NRCs, but suspect or the COVID positive sick SAM children are to be provided services in the dedicated COVID centers, and we have the pediatric wards within the COVID hospital, but we have to make sure that the proper referral arrangement is done and the routine follow-up is carried out through the teleconsultation. So these are some of those policy guidance which have been prepared based on the consultation, based on the available evidence, based on the evolving pandemic which is happening in the country. So thank you very much for giving this opportunity. But I think we need to learn from this, the various guidelines and the various experience. Thank you very much.
Thank you, Dr. Ajay. So I think that's absolutely very clearly, very succinctly you put up the issues brought up by the government of India. But two quick questions. Providing district level care, the care for COVID mothers, COVID suspect mother at the district level has a creation of a separate COVID ward being promoted. And two, since we have clearly defined buffer zone and this thing, containment zones and all, as the pandemic is evolving, do you think the areas will keep on changing? And how will we sort of integrate the management here? Now that once we have defined it, we are quite sure in 3 weeks' time, the zones may start changing, some will become negative, some will become positive, and then how quickly and who is to take the call on this?
As you must be aware that defining a containment zone or defining a particular zone, now it is the responsibility of the state government. The states are taking it, but defining a particular area as a containment zone, district authorities are taking a decision. And to be very frank, all these guidance on containment zone, they are more applicable in terms of providing services in the community. That's more critical and important. But if you look at the facility-based care, you have one SNCU in a district. Now that SNCU has to provide care to all the sick newborn needing services in a district, whether he's from a containment zone or whether the sick newborn, positive sick newborn is from outside. The services needs to be provided at the SNCU, because it is not possible to have a dedicated COVID SNCU to be created at this point of time. That's why this kind of a decision was taken. But in terms of so-called the SAM children which are positive, they can be managed in the dedicated pediatric wards. But at this point of time, because number of cases are less, so there is and we have 2,000 dedicated COVID health centers. We have around 600 odd dedicated COVID hospital. And the preference is that all COVID positive people need to remain, kind of a disconnected from the general population. So they need to be isolated. So that's why this policy guidance has been designed.
So finally, coming after the end of the marathon session, I think we have few quick questions which has to be answered. One was regarding, I think panelists can answer that. One was regarding if you are supposed to do rooming in and have 6 feet distance between the mother and the child as per the recommendations. How do you go about doing a skin-to-skin contact? This was asked by one Dr. Pooja.
I think by now Dr. Khera is very clarified that irrespective of the COVID status, we have to continue skin-to-skin contact, early breastfeeding, and routine care only. Except that we have to change the mode of hygiene in the sense that we continue with the hand washing and wearing mask and cleaning the surfaces. If these are continued, there are no changes to be made. So baby can be kept bedded in with the mother also.
Yes, Dr. Sushma and Swati, any comments on that? Quick.
I think it would be essential that we promote this, but at this moment, I think it's easier said than done.
Yes.
That's true, because actually it becomes, because even the mothers are sometimes getting very apprehensive regarding their own child, and especially if the mother is positive and the child is testing negative. That's what I found here. That she's very apprehensive to even to keep the child with her. She said, she doesn't want it to be positive.
Are there any guidelines that whether we should test all these children? There are no guidelines.
No, if the mother is testing positive, then we do test the babies.
Yes.
Unless the baby is symptomatic, we don't test.
No, if the mother is positive, every baby is tested. But
Yes.
the latest guidelines are going to prevent us from testing asymptomatic mothers. So then where is the question of testing so many babies?
Yes.
No, right now it's very clear that you have a baby, you have a mother who's positive, her baby is to be tested. And the issue of the mother getting paranoid about not looking after her baby has to be tackled by us by talking to the rest of the family members. We need to talk to the husband, the mother-in-law, and tell them that, look, whatever milk she's producing is actually beneficial for the baby. And I've done this, so I know that, yes, it has helped in such cases when the mother is herself paranoid and the others also feel that, she is the villain and our grandchild might get the infection from her. So it's our counseling which really helps, and it has helped in a few cases that we have counseled.
I think the stigma is much more than what it should be. The stigma is not only for a mother baby, the stigma continues for healthcare professionals, for other people who are falling sick and then they're rejected in the community that they come from. I think we need to work towards eradicating the stigma towards this illness.
I think, Swati, rather than stigma, it is a kind of a apprehension regarding the whole disease that people are trying to, a kind of a anxiety or a terror complex which they have, even the professionals have developed on that.
Yeah, so it's all related to the psychological safety that they keep feeling unsafe, and there is that fear and paranoia. That's what is giving rise to the stigma. So the more the counseling is done, the more even the neighbors, if they understand that, okay, home isolation, it's happening. We are seeing in the news that even doctors who are in home isolation, they are asking them, the neighbors are asking them, go to a COVID care center, don't stay here. So if they're explained what is to be done, and I think, Swati, in times to come, things are going to be better in terms of people understanding it. Right now, there's a lot of fear related to that. If I develop the infection and, I might die tomorrow.
Yeah, this fear remains.
I think, Dr. Kera, I think from ministry, we should also ask them to have an addendum on counseling sessions for the healthcare workers, for themselves, for their own support systems, because I feel a high degree of anxiety in many of the healthcare workers regarding the issues. And I have been having difficulty in really counseling themselves also before they start counseling the, parents and all. So that's one issue.
Sitaraman, we are doing it on a regular basis. Although people will not advise having face-to-face meetings, but it is so very important. The Zoom meetings don't really help in this kind of counseling. So talking to the support staff, talking to hygiene helpers, talking with the nurses, talking with the residents. It's an ongoing, every day, almost every second day, you need to address that group of people. Only then their fears are getting allayed, or they are getting more enlightened regarding what this whole thing is about and what is permitted, what is not permitted, what should be done. Everybody is like, I had a little bit of sneezing and cough. Should I get myself tested? I have had a contact with this. You are in the operation theater where a cesarean has been done. You are like, God knows how many feet away, maybe just at the door and peeping in and talking something. Then you say, that lady turned out positive. Do I need to go into quarantine? So it's a constant thing that you need to counsel, and it's helping. It is helping. It's becoming better. 1 month back, we were in a much poorer state of things as compared to now, middle of May. Yeah.
And I think
one more query.
Yes, sir.
One question was that whether the mother should wash their breasts or not. The answer would be, I think there is no need to do any
There's just one daily bath is what is required, and she doesn't need to wash her breast every time or clean the breast every time before feeding. Respiratory hygiene, hand hygiene, and cleaning the surfaces, and breastfeeding the baby directly.
I think we have come wiser from our experiences with this thing, because the international speakers also were very clear about how liberal they are when they are handling these mothers. And of course, my some relief is there that, especially for the milk bank, I think Swati would also be slightly more comfortable looking at the fact that if the mother is clinically asymptomatic, we can
That's what
collect
we
the
are
milk.
doing.
Clinically asymptomatic, we collect the milk, but the suggestion by Gilead, like quarantine that milk for 2 weeks, reconfirm from the mother whether she is okay, and then proceed to pasteurize it. I think that would be a line of action which we should adopt.
Yeah. Sounds very sensible. Yeah.
Yes. Yeah. And any more questions to be taken up, Dr. Ketan, please?
Yeah, I think most of the questions have been answered. There were a lot of questions on when to test the baby, but now I think those have been answered. Are there any specific symptoms in newborn baby? What are the symptoms that you are finding in the newborn baby? Madam Swati or Madam Sushma?
Yeah, we've tested 10 positive babies so far. None of them has shown any symptoms to suspect that it could be because of the coronavirus. They're just like any other normal baby, routine problems of feeding or jaundice or such other issues. I would also like to point out that so far none of the NICU babies has tested positive. So if in due course of time, since it's an evolving pandemic, we really don't know what to expect in the future.
I have a different experience with that. So we've actually not had a positive baby. 2 babies who were born outside, and they came later when the mother was taking care of the baby. So was it horizontal transmission? Possibly, maybe. Those babies also eventually turned out to be negative on the second testing, which we had done at that time. So those babies didn't have any symptoms. But we've had babies around 6 weeks of age who came in with respiratory distress. That baby tested positive. That was in the Sari ward in pediatric. And eventually we lost that baby very quickly. There's another one that I've admitted yesterday who has come at 14 days of life, born at Lady Harding, absolutely fine. Mother is negative. Mother was tested, containment zone. Mother is negative. The baby is now come on 14 days of life yesterday with fever, weight loss, and some respiratory distress. Well, it could just be that there is weight loss, there is fever because of that dehydration thing, and the baby has tachypnea. So we've tested the baby, we've admitted in the neonatal COVID facility. We'll see what the results show. So as we get more into the pandemic, we are going to get babies who are beyond the immediate neonatal period into the later part of newborn period, and they may be picking up infection horizontally and coming to us. So we really need to be watchful as to how things evolve.
We too had a similar situation when the 20-day-old child presented to us with fever and actually evidence of sepsis, and that child did. We could not save the child. He turned out to be COVID positive, and mother was COVID positive at the time. And it initially was negative, and subsequently on 20th day, the child was brought to us in a very critical condition. So I think what Dr. Sushma is saying, we may have to look beyond neonatal period for the child to be testing positive. I think that's one thing we have to do. But another thing, just as
can there be any guideline for those mothers who are negative and the child is positive, whether they should do direct breastfeeding or the mother has got risk of reverse transmission?
Dr. Ketan, we are not even testing the babies of negative mothers. We are only testing when the mother is positive. Sorry?
This is regarding the
babies are not being tested right at birth. In all suspect mothers, we are not testing babies right at birth. Mothers are being tested. If they turn positive, if the report comes positive, we test the baby. The baby, as I showed in this thing till the 15th of May, 30 such mothers were positive, but the babies were negative. And all these mothers are quasi-symptomatic or absolutely asymptomatic. None of
Question is
them
very
have been
different.
sick enough to require hospitalization beyond birth and stuff like that.
Question is
In the
different.
event
But
of
if the baby has contracted contracted COVID from not from mother but from other source, say father or other family member, and baby is say 1 month old, what advices you will give if the mother is negative?
So it's the baby who is positive. Mother is negative.
Yes.
The mother should
Yes.
take care of the baby, hold the baby, breastfeed the baby, because baby is kind of not transmitting back to the mother. The father, if he is positive, he should be in home isolation in one side or whatever, as the home permits, or he goes to COVID care center. But the baby is to be taken care by the mother, and baby, whoever has come positive, not in my hospital, but others who keep asking me or consulting me, on the second testing, those babies have turned negative and they haven't been symptomatic, such babies. I only told you one example of a 45-day-old baby who came in with respiratory distress, and we lost that baby, who was in the pediatric SARI ward. Who was positive.
One very quick question to Dr. Khera on the healthcare workers. And the issue was regarding are there any clear guidelines regarding which level of pregnant healthcare workers should be avoiding COVID duties? Because the general statement had been that pregnant ladies and lactating women for healthcare workers should not be put in COVID duties, while I think UK had a slightly different issue regarding pregnant women. They confirmed that any lady below 28 weeker as a health worker need not be prevented from going to COVID duties. They can go. But here we don't have any clear guidelines on that.
No,
A general
because
statement.
yeah, this is an area, because I mean taking care of the safety of the health worker
Yes.
is absolutely very critical and important. And states are designing, like if you go to Delhi, they have the different guidance. They work for 7 days, then they have a break. So at different places there are different guidances available, but the broad guidance is that people who are 60 plus, who have a comorbidity, they should avoid examining or participating in managing those patients where there is a high chance of positivity, as a broader principle. But states are designing their own guidance. But you specifically asked about a pregnant health worker. Yeah.
So the question is related to a pregnant healthcare worker.
Yes,
So
I get.
do we have some guidelines for that? I think we don't have. Institutionally, we have also kind of evolved something like what the UK thing is, that not in their third trimester, not posting them there in the third trimester, but earlier they are working. They may not be working in the red zone of the hospital, but they certainly are working in the orange zone, and as well as green zone is absolutely fine, but they're working in the orange zone as well. And this thing about healthcare workers being let off for 14 days or 7 days after doing work, after working in a COVID facility also is actually unfounded, unless they've had an exposure, in which case they go for quarantine. But what's happening is they're being laid off for 2 weeks, which is creating confusion, and it's halving your, it's halving your, half of your healthcare staff is away. So this needs to, and I think there is a government guideline which has come in only recently, maybe yesterday or day before, which says that this is not to be done. No, you can give a layoff period.
That's why things are evolving on a daily basis.
True.
In terms of HR management, which kind of HR is to be placed, and those kind of things.
True.
I think Dr. Ketan, I think you take over. You can sum up the whole thing. Yeah.
Yes. So we are coming to the end of the session. So some of the things in very short, I would say that this whole issue is evolving day to day with newer evidences and newer logistics and management part. More issues are with how to implement the things, but then so far as scientific rationales are concerned, we are sticking to the old same school of thought of continuing routine care of the newborn with skin-to-skin contact, delayed cord clamping, including contact, early breastfeeding, continuing breastfeeding, rooming in, mother taking care of the child, irrespective of the status of the mother or the child, and about milk bank to be on safer side, we can come to a conclusion that we can take donation from any donor with a history of being asymptomatic or without any contact at the time of donation, and then wait for 14 days and then again confirm whether the donor has become symptomatic or not, and then we can take up that donation for pasteurization. I am very much thankful to all the panelists, especially the guests from overseas and Dr. Ajay Khera for giving us a very clear guidance, and our own faculties, Dr. Sushma ji, Dr. Swati ji, Dr. Sitaraman, and I'm very thankful to Ruchika from PATH and the whole team of the PATH who has been working on the back end for making this very successful and very smooth. This is one of the most smooth Zoom program that I have attended over the last few weeks. With this, I think we end this program. Thank you all, and we hope that
just one word, Ruchika. Yeah. There has been quite a lot of demand for some of the presentations and some of the questions.
Yes, we have already declared. We have declared that
will take care of that.
Yeah. We will email the presentation to all the registrants who have registered for this seminar. And I hope that with newer evidences, we will gather again after about a month if there are new points to discuss. Okay, Ruchika?
One second, Dr. Ketan, if there are any questions in the question answers which have not been answered as yet, they can be mailed to us or they can be put on the group, and we would answer them for the benefit of the viewers.
Yes, madam, most of the questions have been answered. I have screened all the questions. The only questions
we've been typing the answers along the way. We've been typing them along the way in between.
Yes, madam. Yes, I could see. The only thing that we didn't touch was regarding what sort of delivery should be conducted at the cesarean or vaginal, because it is out of our purview. We didn't take up any of those questions. Otherwise, most of the questions have been answered.
No, I think we are clear on that. Our obstetricians are very clear that it's not about choice. It's not about doing a CS in a COVID. The COVID status does not kind of dictate the mode of delivery. It is her obstetric status or medical status which dictates. So as you saw in our cases till now, 30% are cesareans and rest, and that's our usual rate. 25, 28%. So it's the same. It's not that like the Chinese guidelines where most of them were all done by cesarean.
I would like to add another point, if I may, that unless there is an indication, vaginal deliveries would always be preferred, because it is much easier to initiate breastfeeding and it facilitates a much faster discharge. So the exposure of the baby and the mother to a hospital environment is going to be remarkably decreased if she undergoes a normal vaginal delivery.
I've got one last question for Dr. Khera. Sir, regarding the research going on, are there any guidelines which can guide whether the testing can be done for the breast milk at different centers or not? Because ICMR guidelines, they have given clear indication that these many indications are there for testing. So we need some more testing for research purpose, say for breast milk.
I think, for research purpose, we can always discuss the matter with the ICMR, and if you have thought process, anything which you want to do, we can always get them, participate in that process. Okay. We can take that matter here.
Okay.
Yes, I think
you also must be aware that recently, ICMR has also launched a research proposal where they are doing the developing a registry of all positive mothers.
Yes.
And when they are developing the registry of all COVID positive mothers and the COVID positive newborns, their follow-up, then you can add, whatever elements of research which you want to add. That's possible.
Okay, got it.
Okay.
So, Ritika, anything left out?
Yeah,
I
Ruchika
think
can
we are
sum up.
good.
Yeah.
Yeah.
Do we call it a day today?
Yes,
Thank you
I
very
think,
much. Thank you
yeah,
all. We leave the
yes, yes. I think thank you to all the panelists and participants. And this was a very fruitful discussion, and we'll share our presentation and also answer, as Dr. Sushma mentioned, their further queries. So we have saved the chat and the Q&A, and we'll be sharing that with you. Thank you so much. Have a good evening.
Thank you.
Thank you. Bye-bye.
Thank you.
Thank you.
good evening.
Thank you. Bye-bye.
Bye. Bye-bye.